So I have no financial disclosures, and as Doug mentioned, I am currently practicing as an executive coach, which will be somewhat pertinent to the discussion. Now, every year, the Lake Superior State University is a fun thing. They've done it for over 25 years. They've solicited from people all over the country nominations for the most overused or misused words or phrases. And this year, based on 2019 input, they came up with this list, some of which I chuckle about, some of which I have no idea, nor have I ever heard. But of course, the number one vote for the most overused and misused words was quid pro quo. Now, I would bet that had they looked at the medical literature, they might have chosen burnout as the most commonly used or misused words.
Hey, Bob, we're not yet seeing your slides.
Oh, we're not. Well, let's see here.
And I definitely want to see that slide. And Savannah, do you also have his slides?
Here we go. I got it.
I do not have Dr. Sawan's slides, but I just made him co-host, so that should make things a little easier.
Okay.
See it now?
Yes, we're good now. Thanks, Bob.
My apologies. All right. So the list of words from Lake Superior State University in 2019, most overused and misused words, quid pro quo. And as I said, I would submit that burnout would probably be on that list if they'd focused just on the medical literature. In fact, if you look at a review of medical literature in 2019, there are over 2,100 publications with burnout in the title. And this year, through just 9 months, over 2,200 publications have been written about burnout. Now, I recently heard a colleague say sort of facetiously, I'm getting burned out on hearing about burnout. And with apologies to those of you who might share that bias, I want to spend just a few minutes framing the issue of burnout before I shift to what we as individuals can do about it. So in 1970, Maslach studied burnout and spent a great deal of effort trying to define it and developing a tool to measure it. And her definition of burnout is characterized by emotional exhaustion, depersonalization, and a lack of efficacy. Her MBI that she developed is still the standard tool for measuring the presence of burnout. And burnout is actually now recognized in the ICD-10-11 coding system by the World Health Organization. And although it's currently not in the DSM, there is a work group that's been formed to more clearly define burnout and to potentially include it in the next edition of the DSM. So the underlying reasons for the frequency of burnout in our literature are, I think, pretty apparent. First of all, it's very prevalent. As many as 30 to 50% of physicians in America at any given time are estimated to be suffering from burnout. And the consequences of burnout are serious and can even be catastrophic. And they include increases in medical errors, worsening patient experience and worsened patient outcome, increased costs of care, impaired health for us as physicians, increased turnover, substance abuse, and sadly, even suicide. Now, it's such a common phenomenon that there's actually even a book devoted just to this topic of physician burnout. And the author of this book is Dr. Dyke Drummond, and he describes the causes, the theories, and some of the practical tools that physicians could potentially employ, along with some of the strategic errors and unsuccessful strategies and magical thinking that he's encountered as a coach who specializes in working with burned out physicians. So when Dr. Drummond looks at the pathophysiology, if you will, of burnout, he identified four major subjects. The first is the very practice of medicine. There's no doubt, right, that the practice of medicine is associated with significant stress. Some would say rivaled only by law enforcement or active duty military service. And in the practice of medicine, we assume great responsibility, but we frequently lack control over the outcomes. And furthermore, our medical culture seems to dictate that everything must be done in the service of our patients, even when at times we feel we cannot meet those needs. And each of us is in a specific job situation. These are the elements of your daily work. And there are things over which you seemingly have little control. These are things like your call schedule, your compensation, your clinic templates, the electronic medical record you use, the organizational structure, the leadership decisions that your institution makes, competition in your marketplace, and so forth. These are all factors over which we have little control as individuals. A third aspect of burnout pathophysiology is having a life outside the hospital, that is, and ideally that's when we recharge our batteries. So unfortunately, a lot of times our work comes home with us, or worse, sometimes it even prevents us from getting home. And then at times there's even additional stressors at home, preventing us from recharging our batteries. Family and relationship challenges, financial difficulties, personal health issues, family health issues. These are all examples of challenges that sometimes we face at home when we should be recharging our batteries. And then lastly, he talks about conditioning of medical education. He actually posits that our system of medical education is almost a form of brainwashing. And it's designed to get us to accept certain characteristics of ideal physician behavior. And that creates a culture where we celebrate workaholics, perfectionists, and those who seem to limit their emotions. And although these characteristics are viewed as skills by some, and our residents might think that they're necessary to tolerate residency or to enable success as practicing anesthesiologists or surgeons. Unfortunately, these skills can be very destructive to our personal health. So what to do? The question's always asked, are there proven ways to deal with burnout? Well, Drummond posits that while problems have solutions, and he makes the analogy, an abscess is a problem and the solution is to drain it. Burnout isn't a problem per se, it's more of a dilemma because it's not a problem with a solution. And as such, it requires management rather than just trying to solve it. So in that spirit, I want to try to focus the discussion today towards one way that we could potentially better manage burnout. Now, there are interventions in the literature, and there's a study in Lancet in 2016 that showed that interventions that are focused both on individual providers as well as those that are focused on systems or organizational strategies are somewhat successful and can modestly lower the MBI scores. Now, a more recent meta-analysis in JAMA Internal Medicine observed that these interventions that are directed at the systems or at the organizational level tend to be more effective than those that are directed at individuals. Now, in the process of examining this pernicious attack on a field that I've loved, I spent a lot of time thinking and wondering why some amongst us seem to be relatively resistant to burnout, despite exposure to the same stressors and the same challenges as the rest of us. So I've tried to learn what I can from the psychology and neuroscience literature, reading some philosophy and spiritual authors, and I've interviewed some of these seemingly exceptional physicians who seem to be resistant to burnout to see if there's commonalities among them. Now, like any significant dilemma, burnout is almost always a consequence of many different factors and influences. And let's use one of our common healthcare system problems as an analogy. Let us compare the epidemic of obesity in our country. So all of these factors listed here are significant contributors to obesity. And the tactics that are necessary to alter these are different in terms of their ease of implementation, their potential impact. And it would be pretty simplistic to assume that any one of these interventions would solve obesity, whether for an individual or for our society at large. And this complexity tends to make successful strategies and tactics difficult to tease out. Now, complexity also can drive some towards a feeling of futility. Certainly, there are some people who struggle with managing obesity who succumb to this sense of futility or to the resignation of one's own sense of control. And this sense of futility can easily devolve into viewing our dilemma as something that only others can solve for us. So it can erroneously create a narrative that we are no longer individually responsible or that we can't contribute to the potential improvement. Now, there's much written about the external factors, system issues, regulatory environment, and lots of other potential contributors to burnout in healthcare. And I certainly don't want to minimize the responsibility, especially for those of us in the leadership roles in our institutions, to try to tackle these elements that we can influence. In fact, I think it's one of our greatest current responsibilities and greatest challenges as leaders. However, today, what I really want to do is shift the focus towards what we can do as physicians, individually and collectively, to go beyond mere protection or minimizing the impact from burnout. I want to focus on joy. I want to investigate how we can reach the state of happiness and joy in, as Doug said, magnificent careers. As Doug mentioned, I was a pediatric surgeon and I loved my career. I really also enjoyed a lot of the leadership roles that I was privileged to hold. And I hope that similar sentiments are common for you, at least most of the time. So it's in that spirit that I want to look beyond the discussion of burnout this morning. And today I want to focus on what we can do for ourselves to find joy in our practice of medicine. Now, our state of happiness is not necessarily stable. It's likely dynamic. And as Archbishop Desmond Tutu suggests, it can be impacted by external circumstances that seem intent on shifting our balance. Ideally, we're relatively flexible, adaptable, resilient, and thus we can fluctuate in this zone here between okay and happiness. And perhaps some of our time we'll spend in the state of ambivalence. But I would warn that spending too much time in this zone of ambivalence is not very gratifying. And it could make us susceptible to the large push or shove in the wrong direction from the influences of life. But what about all our colleagues who seem to reside in this green zone of happiness most of the time? They seem resistant to the forces that might push one towards exhaustion or cynicism or worse. These colleagues are characterized as optimists, they're pleasant to be around, and they're described as nice people. And they tend to have very successful practices and careers. Now, there are two common misconceptions about these happy people. One is that the career success is the cause of their happiness. The happiness is the effect. The second is that these people are somehow endowed with some innate attributes. I want to focus on this issue of success begetting happiness. This is a commonly held misconception, because in fact, research suggests the converse is true, that happiness drives success. In fact, a meta-analysis of several hundred studies published in 2005 showed that people who are happy function at higher levels. In fact, they're more successful by any measurement, whether it's accomplishing a simple task in a psychology laboratory experiment or in the multiple domains of life like friendship, marriage, income, work performance, etc. And interventional studies have shown that the activities that put people in good mood tend to make them feel better, and they then perform better both in simple and complex tasks. Now, as for the theory that these happy people have innate or intrinsic talent for optimism or happiness, psychologist Sonia Lubomirsky, who was referenced on an earlier slide there, she actually estimates that approximately 50% of one's happiness is intrinsic or a set point. And if it's, in a sense, it's like one's happiness metabolism, if you will. Now, whether this predisposition is genetic or environmental is certainly open to debate. My sisters and I share a common set point that I've always attributed to my father. He had a strong belief that one could, in fact, he would insist should, always try one's darndest to overcome whatever challenges life can throw at you and to keep a sense of humor no matter what. Throughout my childhood, this was demonstrated every day when he put on his prosthesis to replace the leg that he lost in an act of heroism in World War II. So he never complained about this disability, and he seldom limited his activities. He was actually a very good golfer. I never did beat him before he stopped playing in his late 70s. And he loved to laugh at himself all the time. One of our family's favorite stories, he was playing golf with some men who didn't know about his prosthetic leg. And in those days, he wore long trousers, like most of the golfers in that era. And he was trying to hit a ball especially hard. He really leaned into it. And as he hit the ball, the spikes on his golf shoes dug into the ground, and the foot ended up rotating 90 degrees to his leg. He didn't seem to notice, and he just started walking down the fairway with his foot pointing in the wrong direction. And his partner said, "Ow, my God, look at your foot." Dad just sort of nonchalantly looked down and said, "Oh dear," and he twisted his foot back in position and kept on walking. And he then noticed that these guys were turning slightly green, and he laughed and came clean about his war injury. And that was the sort of sense of humor he brought to all of his life. Now, I don't know how much of my dad's happiness quotient or his set point I inherited, or how much I just learned watching him as a great role model. But I am certain, absolutely certain, that regardless of one's intrinsic happiness, there are tactics and behaviors that we can practice and we can develop as skills that can improve our happiness. And we're going to talk about that. If you accept my premise that happiness is a precursor to joy, then we probably should be learning some of these skills to increase our tendency towards happiness. And the psychology literature contains lots of peer-reviewed studies that demonstrate we do have great capacity for shifting one's affect and mood. And there's increasing neuroscientific evidence that our brains have that capacity to change. So what are some of the factors or behaviors that we can leverage to shift our affect or mood? Well, a lot of studies have demonstrated several practices that are potent vectors to move us along to the right on that affect curve. And a great place to start is the practice of reflection, taking stock, recognizing and acknowledging what's going well, as Doug referenced in his preamble. In our case, that's maybe a chance to celebrate what a privilege it is to be anesthesiologists and surgeons. Now, all of us were attracted to these careers for many compelling and honorable reasons. We're attracted by the opportunities to use our intellects, our breadth of knowledge about physiology and pathology, and to be able to combine that with the privilege of using our physical skills to decisively intervene in patients. It's an opportunity for us to be craftsmen. There's something really deeply gratifying about performing a perfectly sewn anastomosis, or restoring blood flow to an area of ischemia, or completely resecting a tumor, or safely intubating somebody with a difficult airway, or successfully resuscitating a critically ill patient. So one of my attending surgeons at that institution in Boston that Doug doesn't like to mention used to love to claim at the end of an operation enthusiastically, "Now that was a TOB, a thing of beauty." And hopefully you all enjoyed your residency as much as I did. I actually loved mine. And thankfully, I've been fortunate to maintain that love affair throughout my career. Now, like all romantic relationships, it's been challenging at times. It's required some compromise, some understanding, tolerance, and introspection. It hasn't been easy. But some of you might have struggled with these potent forces that impact our lives and seemingly over which we have no control. And while I haven't been spared entirely the challenge of balancing my career and family and other life passions, it's my assertion that if we rediscover our happiness and our joy, and we realize that there are behaviors or skills that can be learned and developed, if we can explore those today, we may be able to maintain our joy in medicine. Now, one of my favorite surgical papers was written by Rick Thirlby, who's a surgeon over at Virginia Mason when he was president of the Western Surgical. And he described with data and humor and lots of poignant observations, but what a fantastic privilege it is to have a career in surgery. So why is a work like this so compelling to me? Well, there's actually a physiologic basis for this. Any opportunity we have to pause and reflect on what is good can actually measurably stimulate neurochemical changes. That's been demonstrated by functional MRI. This practice of purposely taking stock of all the good things that we've experienced in the day is difficult, especially because of our human nature where we tend to dwell on problems, mistakes, or challenges. And in addition, the culture of medicine has always placed a premium on confronting our failures, acknowledging and holding one another accountable, and focusing on improving ourselves, all in the name of care for our patients. You add to that the seemingly persistent measurement of our performance by so many others, payers, administrators, regulators, etc. It's pretty easy to succumb to the conclusion that I'm just not good enough. And this repeated negative feedback is cumulative and it can be destructive. So I want to reiterate, the neuropsychological experiments that have documented that when one's mood or affect is positive, one can function at a higher level. You can demonstrate better problem solving, more creativity, more tolerance for challenges. And these challenges are inevitable. We are going to encounter them. So remember, happiness begets success. So purposely taking stock of the good things in our practice of anesthesiology or surgery can prepare your brain to actually function at a higher plane and bolster your resilience. There is a best-selling book that I would highly recommend that in practical ways builds on this premise. It's written by Shirzad Chamine. It's called Positive Intelligence. So we now hear that there's a lot about practices that might help us as physicians under stress. And some schools like ours offer classes for faculty members and residents on mindfulness and meditation. Some hospitals offer yoga classes, massage sessions, exercise classes, and so forth. I know of only a few physicians who actually take advantage of such offerings. Some of you might be skeptical of such approaches as antidotes to burnout or tactics to build one's resilience. In fact, even the term resilience makes some physicians just roll their eyes. One of my colleagues has opined that by offering such practices to physicians and focusing on our resilience, our institutions are perhaps trying to make the canary stronger without taking responsibility for changing the toxicity of the mind. Now, that might be partially true in some situations. However, again, the research evidence is striking that consistent practice of some of these activities like meditation and mindfulness training and some others cause positive changes in one's affect and in one's brain regions associated with happiness. So these are practices that we all can learn. They're not just the domain of spiritual men and women, and they have measurable positive impact on all people during their everyday lives. So achieving happiness is valuable, obviously, and yet clearly not easily done. It's also not the same as joy. Joy is a deeper, more enduring, and more powerful state. It helps us navigate the certain assaults of life's challenges. It keeps us in balance. One of the ultimate books on this topic is appropriately entitled The Book of Joy. This was a best-selling book in 2016, and it's the written summary of the week that the Dalai Lama and Archbishop Desmond Tutu spent together sharing their perspectives on joy. Now, these two are remarkable spiritual leaders, and yet they have not been spared from the challenges of life. Both of them have been exiled from the countries they love. They've had threats on their lives. They've been separated from family members, loved ones. They've been exposed to racism and many other inequities. But despite the differences in their religious beliefs, they shared many common beliefs and behaviors that can help give us some ideas about battling life's challenges in ways that can bring us joy. Indeed, the Dalai Lama actually describes the Buddhist concept that joy is the essential nature of mankind, and that our desire to return to that state of joy is one of mankind's goals. And he also asserts that everyone can realize joy through cultivating these skills. Now, a different but somewhat related framework to consider is from Okinawa, where there are more, per capita, there are more people who live over the age of 100 than anywhere else in the world. And this is a place where the concept of Ikigai was embraced. Ikigai roughly translates into life's purpose. Why does one live, or why does one get up in the morning? And it's displayed in this figure. So here, the Ikigai space is where one finds the overlap of doing what you love, doing what you're good at, doing what you're rewarded for, and doing what the world needs. Now, Ikigai is not just a state of mind or a state of being, but it's the action that we do to keep us in harmony with our purpose. Now, when I looked at this construct, I thought, we are really fortunate to be in the careers that we are, because I think it sets us up well to find that intersection. In fact, I can't think of too many other careers that provide such an opportunity. But what about those of us who are in these orange areas here, and they just haven't been able to find or stay in this zone of Ikigai? What are some of the examples that we as surgeons or anesthesiologists can incorporate the principles of leveraging happiness to bring us much closer to joy in our work? And how do we keep that joy in our work balanced with other parts of our lives? So as I mentioned, I interviewed several physicians who, in my judgment, seem to live in this realm of joy in their work. I wanted to understand how they do it. Based on these interviews, my own personal experience, and a wide range of literature, I'm going to propose a toolbox of several practices that we as physicians can use in seeking joy. Their ease of implementation and the benefit that each will provide may vary by individual, but I encourage you to consider each of them. First, spend time at the end of each day reflecting on 3 things for which you are grateful. Examples might include a heartfelt thank you that you received from a patient, or the great teamwork that your OR team demonstrated that day, or the great skill that one of your trainees demonstrated as they improved in their growth as an anesthesia or surgery resident. Once that becomes a habit, try to take it to the next level and enter those grateful thoughts into a journal. Studies have shown that people who begin the practice of gratitude journaling actually demonstrate a significant improvement in their affect, and that improvement in the affect can be sustained for many weeks thereafter. So this habit, like many others, is simple in concept, but it does take some diligence and practice. But people who consistently stop and take stock of what went well or what made them feel good that day actually can recapture those warm feelings. And then when you write it down, it goes a step further. It actually hardwires those feelings. So these warm feelings can actually change your brain. In fact, again, functional MRI studies have shown that gratitude journaling increases the ability and the activity in specific areas of your brain associated with altruism, the ventromedial prefrontal cortex, and can result in more altruistic behavior. Second, look for the humor in life. All of my non-random sample and interviewed physicians demonstrate great senses of humor. All are able to laugh at themselves. Humor doesn't need to be a distraction or imply a lack of attention to the important tasks at hand. Provided the humor does not have malice or derision, it's a superb way to make others on your team relax and be at their best. Even the Dalai Lama, 2 spiritual pious men, the Dalai Lama and the Archbishop, demonstrated fabulous senses of humor during their week together. They were often teasing one another. Third, be intentional. Begin each day with 3 thoughts about positive things that you're going to do today. Now, I would suggest that these things not be accomplishments per se, like finishing that manuscript or submitting that research grant, but rather they should be things that you could do to benefit others. Consider writing a note to someone who might be struggling, or thanking someone at the hospital who does a great job but doesn't get acknowledged, or learning something new about one of your OR team members. Fourth, be a leader. It's clear that leaders in healthcare are often less negative and they're less prone to burnout. They're often optimists who relish looking beyond the problems towards opportunities. The likely explanation for this relative resistance to that major element of burnout is that sense of loss of agency or autonomy. Being a leader gives one an opportunity to make an impact and thus can potentially assure one of their own sense of possibility, of relevance, of value, and of control. So leadership in healthcare doesn't have to be limited to those of us who have a title with assigned responsibilities. Our institutions are constantly looking for physicians who are willing to engage in some leadership role, whether it's in quality improvement or operational teams or designing clinical programs or clinical facilities or roles in student and resident education and so forth. The role does not need to be large, but it should have some significant impact on your own professional activities so that you have that sense of agency and that value and that they can be cultivated. Now, one other leadership opportunity that we can leverage, creating joy for ourselves and our teams, exists on an almost daily basis, and that's in the operating room with the preoperative huddle or timeout. Now, the old hierarchy model of the surgeon as captain of the ship in the OR has certainly been recalibrated. But I would propose that we still have a major leadership responsibility, and that we can certainly set the tone for our team. So making an effort to earnestly connect with each team member when they introduce themselves and trying to make them feel valued and appreciated. At Children's Hospital, Jeremy Gajdashek was instrumental in helping us create a very robust checklist that also includes a post-op component conducted at the end of the operation. And one of the required queries is, are there any improvements? And sure, this was intended to call out things that might have gone better, but it's also a great time to acknowledge your gratitude when everything went perfectly. Thank you, Jennifer, for getting that extra piece of equipment and getting it set up without delaying the start of the case. That was really helpful. Or Sally, boy, I know that was a tough intubation and you did a fantastic job. This sort of expression of gratitude is beneficial to the recipient, also improves the team dynamic, and of course you will be working with these people again, but it also brings benefit to you personally. Fifth, be a teacher. All the physicians that I interviewed have practiced at teaching institutions, and all of them described the opportunity to train young surgeons and anesthesiologists as one of their greatest joys. These same joyful physicians are also viewed as great mentors. Now, mentorship and teaching have a lot in common, although some of these gifted surgeons described a subtle but real difference. One in particular said that he viewed his service as a mentor as giving him even greater joy than teaching. And he differentiated mentorship as being future-facing, as he attempts to make his mentees focus not so much on the issue or the task at hand, as much as envisioning the possibilities for what could be. That spawns optimism for the mentee and for the mentor. And what I find noteworthy is that all of these physicians that I interviewed are widely known as great teachers. Now, some might ask, what's chicken and what's egg? Does the teaching or mentoring bring them joy, or do they bring their joy to teaching and mentoring? I don't think it really matters. For one of the great things about joy is that it is self-fulfilling and highly contagious, and everyone who's exposed to it can derive great benefit. Sixth, learn to cultivate compassion. Now, I've written about the importance of love in surgery. And by love, I mean the actions associated with empathy and compassion. I would go so far as to suggest that their importance in the practice of medicine is paramount. There's been a crescendo of attention focused on compassion training for us as physicians. I want to emphasize that this is not just about meeting the needs of your patients, but it's also about learning how compassion can bring you greater joy. The neuroscience literature again shows conclusively that feelings associated with compassion excite regions of the brain that are associated with happiness and joy. And by the way, it's also really important to learn to show compassion towards yourself. 7, belonging to a community. Collaborating with others. These are irrefutable sources of happiness and joy. Well, certainly, COVID's made this more challenging, and Doug mentioned the current environment of politics in our country. But the human interactions with our professional peers is really impactful. Having a group of people with whom you can let your hair down and also share your successes is a documented, effective strategy for bringing joy. Now, these gatherings can still be replicated virtually, as we're doing this morning, and are especially important currently, given the added stress of the pandemic and the political divisiveness. Some have posited that a corollary to this power of community is the opportunity to gain joy by giving to others. So volunteering enables one to give without the same sense of professional obligation. Many of the physicians I've talked to who are active in the global health domain or who provide care in disaster zones report that they gain a great sense of joy from that work. So active engagement in a community is beneficial both to you and to others. And finally is to consider coaching. I think this is a valuable but underutilized skill in medicine. I mentioned at the beginning that I am working now as an executive coach, working primarily with physicians. But coaching shouldn't be limited to those who are underperforming or struggling. I have benefited from executive coaching myself when Children's Hospital offered coaching to many of its senior leaders because they had a belief that leaders' effectiveness could be maximized by coaching. And I've supported coaching for several surgical division chiefs on that same premise, that I wanted to help them amplify their leadership skills. So yeah, I've also had to engage coaches to help some surgeons who are struggling. And while it's not a magic bullet, the ability of coaches to help physicians find their strengths and the power in their lives can help bring them more joy and to resurrect a struggling physician's career. It's repeatedly impressed me, and to me, it's justified the investment. In fact, a recent paper from Stanford and the Mayo Clinic in JAMA Internal Medicine demonstrated that coaching can actually reduce emotional exhaustion, improve the sense of quality of life, and increase resiliency for physicians. Now, just a brief digression, there are some differences between coaching and mentoring. In its most effective form, coaching is not prescriptive. It's not the coach telling client what they should do. Instead, a successful coaching relationship is one where the coach helps the coachee identify his or her challenges or opportunities and helps the coachee create their own plan for addressing those opportunities. So good coaches ask lots of provocative, deep questions that enable the client to find the answers for themselves. That's important. The coachee's answers often create their own sense of ownership, of responsibility, of agency, and power. And these changes are often huge steps towards realizing happiness and joy. And getting back to burnout for just a moment, some of you might be skeptical about my premise that joy can be a prophylaxis or an antidote or even a tool for managing the challenging dilemma of burnout. Now, just as diet alone might not fully address obesity, joy is only one of the possible tools for restoring the balance and the joy and the altruism in our professional lives. And because rediscovering joy is something over which we have some control, it has the potential to be very impactful. Restoring one's own sense of control is one of the common themes amongst all the proven burnout interventions. Now, I've presented an overview of a vitally important topic for us as physicians. I'm convinced that all of us entered our medical careers with great joy. Along the way, through our busy careers, some of us lost some of that joy. Just as the Buddhists assert that joy is our natural state that we all seek to rediscover, I hope that those of us who are struggling or even suffering can rediscover the joy by taking charge of our happiness and moving ourselves along to the right on this emotional bongo board. The stress of practicing surgery and anesthesia in the 21st century of America will not lessen. But if we can leverage these principles to help us find our joy, we'll be more immune to that stress and we'll continue to thrive. So my hope for all of us is to find our own way to cultivate happiness and joy in our lives as physicians. We have the privilege of providing a great service to humanity, as Doug mentioned, and to impact countless lives through our skills. I will leave you with 3 summary, high-level thoughts about how we can rekindle our joy. One, if we acknowledge our gratitude for our magnificent careers. Two, if we positively reframe our perspective about the challenges of our lives by using some of these tools. And three, if we harness our capacity for compassion, we can find joy in surgery and anesthesiology again. I believe firmly that with some focused effort and skill development, we can try to change the things over which we have some control, and we can reclaim that joy that brought us into this fabulous career. That's my wish for all of us, that we optimize our joy in medicine. I thank you for the privilege of speaking today about this important topic, and I'd be happy to try and answer any questions.
Dr. Sawin, thank you so much for a fantastic and uplifting talk this morning. I do think this was fated to be the perfect thing for today, as Dr. Wood has said. I want to open this up. We usually, in the Department of Surgery Grand Rounds, leave it open for a few minutes for anyone who would actually like to speak their question or comment with Dr. Sawin, and then after that opportunity, I'll moderate the chat.
I see one of the questions was, what are thoughts about forgiveness to rescue oneself from stress and prevent impending burnout? Absolutely. I think that's key. That's why I mentioned we have to learn to show compassion to ourselves as well. And this is something that the Shirzad Shamin book addresses, learning how to handle what he calls the saboteurs that we all have that try to tell ourselves that we're doing bad things. It's a good read.
Good morning. My name is Burkhard Magnussen. I would like to take one moment to thank you for this excellent lecture. I found it encouraging and inspiring. And indeed, as Dr. Wood said at the beginning, very timely today. I wanted to take one brief moment to also introduce myself to everyone on this Zoom. I'm the current interim chair of the Department of Anesthesiology and Pain Medicine, effective November 1st. I have had the privilege to serve in this role before, as many of you know. That was about 7 years ago when I served in the role for a duration of about 15 months. I'm now back and encouraged to be serving in this role at this time. As you know, and as we all are quite aware, there's a lot going on in our world, and Dr. Wood greatly talked to that. I would like to add to one of his comments that not only are we as leaders available for you all to talk to, but I would really encourage everyone to reach out to each other to amplify the opportunity to talk and be compassionate. And I don't have a question for you, but thanks again for your excellent lecture.
Thank you for your comments. I noticed here that Sam Arbabi had a comment that humor is also important in our interfacing with patients, making patients relax and smile. I agree, Sam. I think that's a very powerful tool in the practitioner's toolbox.
Perhaps I do have a question, if that's okay. I remember a time where we had a faculty person amongst us that we could all turn to if we were in trouble. There was even hotlines. I know that there has been a hiatus and now there's opportunity to do so. Can you speak to opportunities within our UW medicine world, how those of us who want to maybe not talk to an individual, but actually have a phone number ready, what they can do. I see Doug is talking.
Yeah, Bob, maybe I might be more up to date if you, you know, yes, there was a peer support program developed a few years ago that certainly in surgery was not widely utilized. I don't know in anesthesia, but this is something that Trish Kritek and Ann Browning and their group have really vigorously reinitiated with training for peer support individuals that cross all the departments. You have champions within the Department of Anesthesia and Pain Medicine. I'll point out Sam Sharar as being one of the leaders of that at Harborview, and I know there are others. And so there's actually a website for this, contact information by site, by specialty. So there is the development of a really proactive peer support system within UW Medicine that should provide resources for individuals to do exactly what you asked, Burkhart, is to be somebody close to you that you can talk to.
Thank you.
Yeah, I don't have the website in front of me, but I'll work with our team so that when we send out the evaluation forms for the grand rounds, we'll try to put a link there for the site.
Sam Sharar just put the link up. Thanks, Sam.
Welcome.
Well, I'd like to thank everyone for being here this morning. Again, especially I want to thank our colleagues in the Department of Anesthesia for collaborating with us in planning this session and also joining us today. I can think of no greater starting example of sort of how to collaborate our teamwork other than something like this. So I want to thank everyone for being here today, and Dr. Sawin, again, thank you for being here. Thank you for your thoughtfulness, your practicality, and also for implicit timing in being with us today on this topic.
Thank you so much, Deb.
And everyone, take care of yourselves and take care of the people around you today.